So this will be the first class we've had on Teams, and hopefully it works out really well. And they'll do a transcription with this, and I guess that automatically comes up, even though I put no transcription. So can you read this as I'm speaking?
I can't see anything when you're speaking, no.
Oh, okay, all right. But you can see the PowerPoint, okay, yeah?
Yep.
All right. So I'm going to discuss the cranium, chapter 11. There's a lot to cover. And on Blackboard, I put some helpful study guides in there. Now, because I only have an hour to cover the cranium, I'll go through some of the anatomy, some of the projections. Tomorrow, I'm going to actually narrate the facial bones and sinus. That's not mandatory to listen to, only this live lecture. So it's up to everyone individually, whether or not they want to listen to it. The same thing's true with some of the study guides. I did put up one of the worksheets that has the anatomy on it and just some questions. Now, those questions are just to see how well you did studying. Those questions won't show up on your quiz. And the quiz, as far as I know, everyone will take the quiz on the skull next week, unless your lab instructor has told you different, because it is up to the lab instructors to decide when they're giving the quiz. All right, so let's get started here. We have a lot to cover. All right, so the skull itself, and I brought my little skull with me. You can see it. Here it goes. He's has 22 separate bones divided into two groups. The cranial bones, there are only 8 of them, but facial bones, there are 14. And today we'll just discuss the cranial bones. Now, the cranial bones are further divided into the skull cap, which is the frontal, the occipital, and the right and left parietal bones, and the floor of the skull, which is the sphenoid, ethmoid, and right and left temporal bones. So here we can see an image here. We have the frontal bone, and we have the parietal bones, the temporal bones. In the front, when you look at the skull face on, it's very difficult to see the sphenoid or the ethmoid because it's in the base of the skull. So, but when you turn the skull lateral, you get to see all the bones of the skull itself. So we can see that the temporal bone is here and the sphenoid is in here, frontal, parietal, and occipital bone. So as I repeat, the lateral bone is, the lateral skull is the only projection that you will see either all the sinuses, all the facial bones, or all the skull bones in themselves. So here we have an image of the base of the skull, and this little part here is the crista galli. That's part of the ethmoid bone. Here, this bone that looks like a bat is the sphenoid. And then we have the temporal bones through here. And there's 2 of them, only one ethmoid and one sphenoid. So those are your only single bones there. Now, with the bones, they're called sutures, and there are sutures that join the bones together. They're basically fibrous joints that connect all the bones of the skull. And we have the coronal suture, which brings the frontal bone with the parietal bone. We have the sagittal suture, which brings both parietal bones together. We have the squamosal suture, And this part of the temporal bone is the squamous section. So it joins the temporal bones with the parietal, and the lambdoidal suture, which joins the occipital bone with the parietal. So everything joins with the parietals. Now, in the next slide, what we'll see is the different points that when the sutures come together, they'll form a little point. The bregna is on top of the head. It's where the junction of the coronal and the sagittal sutures meet. The lambda is in the back of the head. It's where the sagittal and the lambdoidal suture meet, so it's right in the back. Fontanelles are areas of incomplete ossification, and those are found in the infant, and we'll take a look at those. There are only 6 of those. Now, the adult cranium usually reaches its full size around age 12. So here you can see the different points that I was talking about. There's actually a couple more added, the asteron and the pterion, and it's where the squamous will meet. So you can take a peek at those. Now, the fontanelles, there are 6 of them. You have an anterior and a posterior, and then the right and left sphenoid and right and left mastoid. So that's why, you know, when you hold an infant, they say hold the head, because there are soft spots within the head, because these fontanelles hasn't joined together and formed the sutures close together. Now, when we talk about skull morphology, we're talking about the classification of skulls due to their shape and their size, because some skulls may increase or decrease the central ray angulation or less rotation when you do them. So it's important to understand the shape of the skulls. The mesocephalic skull is a normal shape and size. The dolichocephalic, and I put that in a hyphenated way so it would be easier to pronounce for everyone, is a skull that is long from front to back and narrow side to side. The brachiocephalic is short from front to back and broad from side to side. Most people know Fred Flintstone, and I always say that Fred Flintstone's the perfect example of a brachiocephalic skull. So the reason why we need to know this is because when you're doing or performing a TM joint, you may have to increase or decrease your rotation on the skull due to whether it's a broad skull or a real thin skull. So a broad skull, the brachiocephalic, requires more angulation than the thin skull, which requires less. So now these skulls, the petrous pyramids, which are part of the temporal bone, form different angles within the skulls. In a normal skull, the petrous pyramid will be 47 degrees from the mid-sagittal plane. In a brachiocephalic, they form a 54 degree, so it gets wider. In a dolichocephalic, the petrous pyramids are only about 40 degrees. So that's why it's important to understand, because like in the brachiocephalic, we see that the width of the skull is about 80% or greater than the length, which is completely the opposite of the dolichocephalic. So here we have the images of the skull shapes so that you have an idea. And these shapes are looking at the skull from, let's say, if you turn the head upside down. So you're looking at it that way. So let's look at these. Which skull is which when you look at these? Does anyone have an idea what this skull would be first? Ladies, any guess? Okay, well, go ahead, Caitlin, then.
Would that be dolichocephalic?
Yes, that's right. Because it's thinner and longer, so that makes this one brachiocephalic, because it's shorter and wider, and this would be a normal skull. Good. Now, like anything, the skull itself has different landmarks in it, and you have to know your landmarks. So the supraorbital groove is the groove above the eyebrow. And if you put your finger on your eyebrow and then push it back, you can feel that groove. The superciliary ridge is just that ridge right across the eyebrows. And the glabella is that smooth part between your eyebrows. Now, the nasion happens to be at the bridge of the nose. The acanthion is where the nose and the lips meet. The gonion is the angle of the mandible. The mental point is right in front in your chin. The inion is that bump in the back of your head that you can feel. Now, the supraorbital margin is if you come up right under your eyebrow, you can feel the very bone, that top part of your orbit. That's the supraorbital margin. The mid-lateral orbital margin is just the lateral part, where the infraorbital margin is the lower rim of the orbit. The reason why we need to know these is because in an abdomen, you use the iliac crest for positioning. In the skull, we have skull positioning lines that we use, and we're going to learn just a bit more about them. Now, the external acoustic meatus is that opening of the ear canal. The auricle of the pinner is just the flap of the ear. The tragus is this part here that almost covers the EAM. And right here is the top of the ear attachment. And that is where the level of the petrous ridge is located. So here are your skull positioning lines. And we have the glabellomeatal line, the orbitomeatal line, infraorbital meatal line, acanthomeatal line. So all these lines are from one part that we learned about, such as the orbitomeatal line is from the outer canthus, and that's where your eyelids meet, to the EAM. So we draw a line from the outer canthus to the EAM. The glabellomeatal line, we draw a line from the glabella to the EAM, and so forth. So these are all the ones that we're going to use when we study the projections of the skull. So it's good to be familiar. Now, one that we don't use that often is the GAL, which is the glabella alveolar line. And that actually connects the glabella to the alveolar process. And the alveolar process is the bottom of the maxilla that comes together and joins to a point. The interpupillary line we're going to use when we position for a skull, a lateral. And that's just basically from the outer part of the orbit straight across. And by the movement of the chin up and down, that's how you make it perpendicular, which you'll learn in lab about that. So here I included these images so that you would get a better understanding of how these lines are drawn and where they are. Now, a very important note is that the orbitomeatal line, the OML, and the infraorbital meatal line, have a 7-degree difference between them. The reason why it's so important is because if the patient cannot tuck the chin enough to get that orbital meatal line perpendicular, then we jump to the infraorbital meatal line, which means our central ray has to change angulation. So if we were supposed to use the orbital meatal line, couldn't, had to use the infraorbital meatal line, we're going to add 7 degrees to the angulation because of it. So that's why it's really important to understand the difference. The same thing, the glabella and the orbital meatal line have an 8-degree difference between them. So let's go in and look more at the anatomy. So first we'll start with the frontal bone, and it has a vertical portion and a horizontal. And the frontal squama, this is what's called the squama, forms the forehead and the anterior part of the cranial vault. The horizontal portion forms, the orbital plates. It's part of the roof of the nasal cavity and the greater part of the anterior cranial fossa. The frontal sinuses are contained within the 2 tables of the squama. So we locate the frontal sinus in here, and there's normally 2, and it has a septum between that join it together. Some people only have 1. Males have a bigger frontal sinus than females. Now, the frontal bone itself articulates with the right and left parietal bones, the sphenoid, the ethmoid, the nasal bones, and the zygoma. And those last 2 are facial bones. Now, the parietal bone, as you know, are located on the side of the skull here. They're more like a square shape, and they have a convex external surface. And the parietal eminence is if you were the widest part of the skull. So in the parietal bone, you have a bump here on the sides. That's the widest part of the skull. And in some cases, if they have to manually produce a technique, they will measure the skull from that part. Now, the parietal bone articulates with each other at the sagittal suture. It articulates with the frontal, temporal, occipital, and sphenoid bones. And here we have an image of the parietal bones, articulates with 5 bones, and the occipital bone, which is in the back of the head, that articulates with 6 bones. So the occipital bone is that bone that's posterior and inferior part of the cranium. It forms the posterior half of the cranial base and the greater portion of the cranial fossa. It has 4 parts to it: the squama, the 2 occipital condyles, which are here, which are going to articulate with C1, and the basilar portion, which is here. What's important about the basilar portion is this part here will join with the dorsum sella of the sphenoid bone to form what's termed the clivus. And that's where the pons sits. So it's the pons of the brain that sit there. So in the occipital bone, you have a hole, which is termed the foramen magnum. And it's a large opening through which the medulla oblongata passes and exits the cranium. And we know that the medulla oblongata, as it exits the cranium, becomes the spinal column and heads right down into the spinal canal. Now, there is an external protuberance, and protuberance are basically bumps. So if you feel the back of your head, you can feel that occipital bone and those protuberances. Now, the occipital bone articulates with both parietals, the two temporals, the sphenoid, and the atlas. The ethmoid bone consists of a horizontal plate, and it's a weird shaped bone, and a vertical plate. And that vertical plate is called the perpendicular plate, which forms the superior portion of the nasal septum. So that's important because that perpendicular plate is going to form the superior portion of the nasal septum. The vonar comes in, which is a facial bone, to join the inferior portion to make that into the nasal septum. Now, within the ethmoid bone, you have two light spongy masses called labyrinths, and they're located between the orbit, and it forms part of the anterior cranial fossa, the nasal cavity, part of the orbital wall, and the bony nasal septum. The horizontal portion of this is called the cribriform plate that contains numerous foramina for transmission of the olfactory nerves. And the olfactory is the sense of smell. It has a conical projection that comes up from the cribriform plate called the crista galli. And we can actually see when we look at the Caldwell projection, the crista galli, because it sits right into the frontal little notch there. And I'm going to show you the picture of that in just a bit. So this is what it looks like. It's pretty bizarre. So now let's talk about the sphenoid bone. So the sphenoid bone is also referred to as a bat, and it's a regular shaped bone, and it's located at the base of the cranium, anterior to the temporal bone, and the basilar portion of the occipital bone. So it consists of a body, and in the body contains the sphenoid sinus, two lesser wings, two greater wings, and two pterygoid processes. The lesser wings arrive from the anterior and superior portion of the body and lie horizontally on each side. It forms the posterior medial portion of the orbital roofs, the posterior portion of the anterior cranial fossa, the upper margin of the superior orbital fissure, and the optic canal. The medial end forms the anterior clinoid process. So here it is. So here we go. These are the lesser wings in here. And this is the greater wing. This is the body of the sphenoid. That's the crista galli of the ethmoid bone. And in the back is termed the dorsum sella, because right above the body is a saddle-like structure called the sella turcica. Now, those greater wings arise from the sides of the body and curve laterally, posteriorly, anteriorly, and superiorly. So they really kind of curve around. And there are three paired foramina situated within the greater wings. The foramen rotundum, ovale, and spinosum. The carotid arteries come out of one, and you have nerves coming out of the other two. The pterygoid process arises from the lateral portion of the inferior surface of the body and the medial portion of the inferior surface of the greater wings. So this kind of gets a little complicated with skulls. That's why I suggested if anybody wanted the PowerPoints ahead of time, it's great to study. And it's also, I'm not going into great detail on the anatomy, but within your chapter, you can really get through it. Now, the pterygoids articulate with the palatine bones anteriorly and the vomer as part of the nasal cavity. So the sphenoid bone is the bone of the skull that articulates with all the other 7 bones of the the cranium, including the zygoma, which is a facial bone. The body contains the two sphenoid sinuses and forms the posterior body wall of the nasal cavity. That sella turcica is a saddle shape, a deep depression, and it houses the pituitary gland. So when we take a look at the sella, here's a side view, looks like a saddle, and the sella sits right in here. The tuberculin sella, which is the anterior part here, the clinoids come down, and it's called the anterior tuberculin sella. The back part is called the dorsum sella, and that joins up with the basilar portion of the occipital bone, forming the clivus, which I had mentioned. And underneath the sella turcica is where the sinuses are. They're down there. Okay. So we talked about the clivus. Also, the optic groove extends across the anterior portion of the tuberculum sella, and the optic canal, which is just an opening in the apex of the orbit. It's between the sphenoid strut, what they call, and that's where the optic nerve and the ophthalmic artery come through. So let's look at the temporal bones, and they sit, sorry, can't talk today. They sit on each side of the cranial base between the greater wings of the sphenoid and the occipital bone. Now, I broke the temporal bones into multiple sections. Some places they'll only break it into 3, but the squamous portion, the tympanic portion, the styloid process it has a zygomatic process, which meets up with the zygoma, which is a facial bone, to form your cheeks, and the petromastoid portion, which contains the organs of hearing and equilibrium. The petromastoid portion is the most densest part of the skull and very difficult to fracture. In the temporal bone, the squamous portion is the thinnest, and that's the easiest to fracture. And we'll take a look at that. So the top here is the squamous part. The mastoid has a process here, this little bump, and there contains air cells within here. We have a styloid process. Whenever we have something pointy like that, it just means it's going to be an attachment of either a tendon, ligament, or muscle. You have the mandibular fossa in here, and that's where the condyle of the mandible sits to form the temporomandibular joint, the TM joint. The tympanic portion, they'll say that's basically been replaced, and it's where the organs of hearing are, but that's really within that petrous mastoid portion. So we went through this. Good. Basically we went through this one too. I jumped ahead. All right. So the mastoid process is just conical in shape, and it projects from the mastoid portion. The petrous portion projects medial and anterior between the greater wing of the sphenoid and the occipital bone. So it's called the petrous pyramid. And what's important about the petrous pyramid is when we look at our images of the skull, we check to see where the petrous pyramids are lying. So with a Caldwell, we know the petrous pyramids sit in the lower third of the orbit. For a Waters projection, it falls below the maxillary sinus, and we'll go through all that. Now, the auditory ossicles are bones of the middle ear, the malleus, incus, and stapes, and they're located within the petrous portion. So let's look at hearing completely. So let's start from the outer part. So you have an auricle or a pinna, and that helps to collect the sound. The external auditory meatus is simply a sound conducting canal. It ends at the tympanic membrane. The tympanic membrane is where the middle ear begins, and that's basically just a thin membrane that helps transmit sound vibrations. Past the tympanic membrane is the cavity, and that's just the space between the membrane and what's termed the bony labyrinth. And that's where the eustachian tube communicates with the nasopharynx for drainage. And you have the auditory ossicles within there. So here's a picture of the nasopharynx and the eustachian tube. And the auditory ossicles is the malleus, the incus, and the stapes. And the malleus handle attaches to the tympanic membrane. The head attaches to the incus. The incus attaches to the head of the stapes, and the base of the stapes attaches to the oval window, which begins the inner ear. And the inner ear is what really contains the organs of hearing and balance. And that chamber is called the bony labyrinth. We have the cochlea, which is for hearing, the round window, and the vestibule, which is for equilibrium, and the semicircular canals are for equilibrium. So here we have an image of this, and another one broken up and just kind of brought in. So let's get right into the positioning now of the skull. So there are 5 common positioning errors that happen when you do any type of positioning for the skull. And that can be a rotation, a tilt, which is like this, excessive neck flexion or extension, and then your central ray is incorrect. So a hyposthenic or asthenic patient is a thinner patient. And as you can see, when they're laying on their side, because they are thin, sometimes the head can come up. So if you place a pillow under the chest, it helps to prevent the downward tilt of the mid-sagittal plane. Now, for a large patient, a hyperstatic patient, because the chest is large, the head tilts down. So if you place a sponge underneath the head, like a 45-degree angle sponge, even you can do that, and that will straighten it out. So let's get right into skull positioning. With the positioning, you need to know what the skull positioning line that we use, what is it? Where the central ray enters or exits, and what position the patient is in. So on this, it's a lateral skull, and we place the head in a true lateral with the side of interest closest to the image receptor, and the patient's body is in a semi-prone or erect position. We align the mid-sagittal plane parallel to the image receptor, ensuring that there's no rotation or tilt. We want to make sure the interpupillary line is perpendicular, and the IOML, infraorbital meatal line, is perpendicular to the transverse process of the outer edge of the image receptor. So the IOML really becomes parallel with the table, okay? And then you just align the central ray perpendicular to the IR so that it enters 2 inches superior to the EAM, or halfway between the glabella and the inion, so you can see it. So here's the EAM, it's gonna go in, and then it's halfway between that glabella and the back of the skull. Here you see it, interpupillary line. So when you look at a lateral skull, you look at the orbital roofs here to make sure they're superimposing. The whole back of the skull should look like one line. And when you look in here at the sella turcica, it should look like one line. If the chin is down too much, then the orbital roofs will separate. You'll get one line here and one line there. Now, if you have a trauma patient and you can't put them into a regular lateral, you can do a cross table lateral. It's done the same way. It's still a 40-inch SID, and we're still centering the same. We just want to make sure that we get the back of the head on. A Caldwell, and the lateral shows all bones of the skull. Now, a Caldwell projection is done PA. The patient rests their nose and forehead against the table, and the orbital meatal line is perpendicular. The central ray is angled 15 degrees caudad, and it comes out and exits at the nasion. And you should always suspend respiration for all your skull work, just so that the patient won't move. You can just tell them to stop breathing. Now, a PA axial Caldwell shows the petrous ridges, this is what's important, in the lower third of the orbit. Now, we do it PA, but if the patient couldn't turn on their tummy and you had to do it AP, you would then, instead of angling 15 degrees caudad, you would angle 15 degrees cephalad. And the difference would be that on an AP skull versus a PA, the orbits are magnified. But always make sure that the Petrus pyramids are sitting in the lower third of the orbit, and that if you look at the outer orbit here to the side of the skull, it should be equal on both sides. That's how you tell rotation. Now, if you do a Caldwell with a 25 to 30 degrees central ray, look what happens to the Petrus pyramids. They come way below the orbit. And the reason why some places do this is to have better visualization of the superior orbital fissures, which are up here. And that's why they'll do it a lot of times, or if they're going to do a sinus projection, sometimes they'll do that. But as we'll learn further on, when you do sinuses, because you're looking at air fluid levels, you're better off always not angling the central ray. You just angle the head instead. So a PA skull is different. Now, for a PA skull, we're still going to use the orbital meatal line, but now the central ray is perpendicular and it's exiting at the glabella. And what happens is when you look at the projection, these Petrus pyramids are sitting directly in the orbit. So that's how you can tell the difference between a PA skull and a Caldwell. The Caldwell, Petrus pyramids, lower third. PA skull, Petrus pyramids, sitting right in between. Boom, there it is. Okay, for a Townes projection. Now, for a Townes projection, we do it because we want to see the occipital bone. We're looking at the back of the head. That's why we do it. The patient is AP, and you tilt the chin down. so that the orbital meatal line is perpendicular. Now, we angle the central ray 30 degrees. It enters about 2.5 inches above the glabella, exiting the foramen magnum. Now, if a patient cannot tuck that chin way down, then you use the infraorbital meatal line instead, have that perpendicular, increase your central ray angulation to 37 degrees, and exit the foramen magnum. Okay? That's why it's important to know about the 7-degree difference between the orbital meatal line and the infraorbital meatal line. How are we doing so far? Okay. Have I lost you? Okay. So you okay, Caitlin?
Yep.
Good. We lost somebody else. All right. So now we look at the Townes projection. So here it is. We see the foramen magnum right here, that nice little hole at the bottom. Inside is the dorsum sella. It should be sitting directly towards the bottom and in the center of the foramen magnum. If it's over one side or another, the skull is rotated. Here we have the petrous portion through here. Here we go, petrous. And this is the parietal bone, and this is the occipital bone. Now, the reverse of the Townes is called the Haas projection, and that's done PA instead of AP. And with the Haas, it's the same thing. Orbital meatal line, forehead down, nose tucked, get that orbital meatal line perpendicular. Angle the central ray 25 degrees so that it exits just above the nasion. And basically, it looks like a Townes projection. Same thing in the foramen magnum, you get the dorsum sella at the bottom. And then what you can do is, here's your parietal, here's your occipital, and your petrous portions, and you can just measure the distance between where the parietal and the occipital meet on both sides to check for rotation. Now, the submental vertical or the SMV projection looks at the base of the skull. The infraorbital meatal line should be parallel with the image receptor, which means the patient puts their top of their head against the image receptor, and the central ray then goes perpendicular and passes 3/4 of an inch anterior to the EAM between the mandible. Now, this is a hard projection to do. And so if they can't do that, you can modify it as long as the infraorbital line is parallel with your image receptor and the center ray comes in perpendicular to the infraorbital meatal line. Okay, so the skull projections are the base of everything. It's the base for the sinuses. It's a base for the facial bones. The difference is on a lateral, your central ray is changing what you're looking at. Whether you're looking at the facial bone or the sinus, the central ray will move forward. Now, here we have a picture of the SMV, and we can see the mandible up and above the base of the skull. We see the foramen magnum and the odontoid. We can see the sphenoid sinus in here and the ethmoid. And the petrous portions are hanging out down here. And what you can do is look at the mandibular condyles to see if they're equal distance from the outer edge of the skull to tell rotation. Another projection, the Waters method, a lot of times is used to see any metal in the orbits. It's used to see the maxillary sinus or all the facial bones in the front. The mentomeatal line, MML, is perpendicular. So the chin is extended forward. The nose, they say, is about an inch and a half off the image receptor. The trouble is everyone's nose is a different size. So it's hard to go by that. You should always go by the MML. And then the central ray is going to exit the acanthion. And this is what the Waters looks like. We do it to see any metal in the orbits. Here's the frontal sinus. If it's a sinus projection, you would just collimate in a little more, and you're looking at the maxillary sinus, and the petrous ridges fall below the maxillary sinus. The TMJ is a projection, it's a law. They call it the law projection or the 15 by 15. Basically, the patient is in a true lateral. The difference is once you get them in a true lateral, you then rotate their face 15 degrees forward and angle the central ray 15 degrees caudad, centered 1.5 inches superior to the upside of the EAM. So that central ray is going to pass through the downside of the TM joint. Now, the thing about this is you're looking at the downside of the TM joint. That's the one you're focusing on, and you have to do both sides. The funny thing about this projection is once you get them into position, you take a projection of their mouth closed and then one open so that you can see the condyle. This is a closed one sitting within the mandibular fossa, which forms the TM joint, and there's the meniscus in here. And when the mouth is open, this condyle comes anterior, and you have a big space in here. Now, for a lateral nose, you're going to do both sides once again. Same thing. Patients in a true lateral position. The difference is the central ray. The central ray is 1/2 inch inferior to the nasion. So basically, you're right on top of that nose, and you do both sides for comparison. So it looks like almost like a carrot and a snowman, huh? The right and the left. And you want to see that because they're looking for any kind of fracture. Now, that brings us to the fractures of the skull. So with skull fractures, there are different types that you should learn. The linear is jagged or regular. The depressed is like taking a ping pong ball and pressing in one little part there. There's the basal skull fractures where at the base of the skull, you can tell if a patient comes in with blood coming out of their ear. A blowout fracture is just the fracture of the floor of the orbit. A tripod fracture is a fracture of the zygoma, which takes place in 3 places: the maxillary process, the arch, and the orbital process. That's what the tripod is. It's got to be 3 places of fracture, and those actually go to the operating room to have surgical clips put in to hold it. And that comes from just basically getting punched in the eye. The Lefort fractures, there are different levels of them, but they're horizontal fractures of the maxilla. A contrecoup is a fracture on one side that was caused from an impact from the other. So if they get hit in the head on the right, there might be a fracture on the left. And a foreign body in the eye is usually caused from metal or other type of fragments, then you always do a Waters projection for that to look in the orbits. This is a Lafort here where the maxilla is fractured. And that's just a linear fracture with all these lines. Now, you also have to know the diseases. So we have them here. I have them all listed that you'll need to know. There's just a few of them. So hopefully next week you're taking this quiz on the skull. You need to review the following projections to include how the patient is positioned, the skull positioning line used, where does the central ray enter and exit on the skull? And those are the Townes projection, the House, the Caldwell, PA, the AP skull. Know these for the skull, facial, and sinus projections. The SMV for the skull and the sinus. A lateral skull, lateral facial bone, lateral sinus. The Waters method, the nasal bones, and the TM joints. Those are your projections that you need to know. Understand what is seen on each projection. Go through the diseases that I've put on this PowerPoint and the fractures. Make sure you know those. Also, I am going to record a narration on facial bones and sinuses. That is not mandatory. If you want to listen to it, go ahead. I did put up some study guides, some worksheets. These are just things to help you study. Some people like to use it, some do not. Some would rather read the book and go through it. That's fine. Whichever way helps you is good. If you need some help or you don't understand, please email me directly. I see my email every day, better than messaging me on Blackboard. And the key word is disease. Do you have any questions at all?
Not at the moment.
Okay, all right. If you do, you know what to do. And this will end the class for tonight. Thank you for coming.
Thank you, Lisa.
All right, then, bye-bye.
Bye.